Let us continue the second session for management of arthritis case discussion. Question number 7. Would it have been reasonable to switch this patient from methotrexate to either hydroxychloroquine or sulfasalazine? Yes, because the conventional synthetic DMARDs are the safe in pregnancy. Question number 8. What are the biological DMARDs that can be used for treatment of rheumatoid arthritis in this patient? Do you recommend their use during pregnancy? Justify. Biological DMARDs includes tumor necrosis factor alpha blocking agents, and these are generally monoclonal antibodies. They includes adalimumab, certolizumab, pegol, and golimumab, and they are the FDA pregnancy category B. As we discussed, all these tumor necrosis factor inhibitors safe in the first and second trimester, but should be discontinued by the third, except certolizumab pegol. Pegol is polyethylene glycol. The only tumor necrosis factor alpha inhibitors that is safe in third trimester. So yes, you can give the biological DMARDs. Recommend use of biological DMARDs during pregnancy. Tumor necrosis factor alpha tumor necrosis factor alpha blocking agents can be used during pregnancy as they are FDA pregnancy category B. And as we know that the pegylated agent certolizumab pegol, it can be used in the third trimesters. But there is one note. Infants exposed to tumor necrosis factor alpha inhibitors in utero should not receive live vaccines for the first 6 months of life. It's very important. Why? Because as these are the monoclonal antibodies, they may suppress the immunity, and if the infant receive the live vaccine, maybe chances of the infection, so it should be avoided. Most important note, infants exposed to tumor necrosis factor alpha inhibitor in utero means biological DMARDs should not receive live vaccines for the first 6 months of life, because we know that the vaccines are given from the first day of the life. That's why it should be avoided till the 6th month. Case 3, a 57-year-old man has progressive RA that has not been responsive to sulfasalazine. He is having difficulty working a full day and is seeking alternative medications. After a discussion of therapeutic option, the patient refuses methotrexate therapy and asks to start hydroxychloroquine. Do you agree to start hydroxychloroquine in this patient? Justify. No, because methotrexate or leflunomide is much better than hydroxychloroquine because he has a progressive RA, and in the progressive RA, hydroxychloroquine will not be significant. Would it be appropriate to initiate low oral dose corticosteroid concurrently if S justify? At what dose if no justify? S low dose corticosteroid is recommended because low dose oral are prescribed on as needed basis. Means if there is a pain for brief periods of severe disease activity while awaiting the onset, because we know that the disease modifying anti-rheumatic drug needs near about minimum 4 weeks to be activate. And the most important here, to manage the pain, the patient can use low dose corticosteroid. Would intra-articular corticosteroid injections be safe and effective treatment options for this patient? Justify. Yes, because intra-articular means the target. They are the safe and effective for pain relief in patient with RA because the onset is immediate. But what is the drawbacks? Effects are short-lived, short time. And what is the advantage? Produce less systemic side effect than oral corticosteroid therapy. So this was all about rheumatoid arthritis cases. Now we will discuss about the osteoarthritis. Osteo. Just I will give the brief about the osteoarthritis. Osteoarthritis. Yes. Osteoarthritis is a chronic progressive condition primarily affecting women. That causes loss of articular cartilage in the hands, knees, hips, and cervical and lumbar spine. Loss of articular cartilage in hands, knees, hip, cervical, and lumbar spine. This osteoarthritis causes significant pain and functional disability. Joint space narrowing without joint destruction. Joint space narrowing without joint destruction on radiograph is characteristic for osteoarthritis. And the osteophyte formation and the bone rubbing against bone are responsible for the pain, stiffness, crepitus during physical examinations. What are the risk factors which can be modifiable? Obesity and the joint trauma. Non-modifiable, advanced age, gender means women's, and genetic. Metabolic conditions. Some metabolic conditions also responsible for the osteoarthritis. What the goal of therapy? The therapeutics of the osteoarthritis. The goal of therapy are to provide analgesia, support daily living activities, facilitate participation in physical and occupational therapies, facilitate participation in self-managed exercise program, minimize disability and improve overall quality of life. And non-pharmacologic therapies include weight reduction and the exercise, improves the muscle strength and prevent the fall. And these are the pharmacological therapy for the osteoarthritis. Treatment is not required during periods when symptoms are absent or too minimal to be bothersome one to the patients. As available drugs are not disease modifying, so we are giving only symptomatic treatment to relieve the pain, and disability. So acetaminophen is a drug of choice. Acetaminophen is also called as paracetamol. Topical agents include diclofenac ointment cream, other non-steroidal anti-inflammatory drugs. If there is an old age, best to use Sulindac because it has a renal sparing effect. Opioid, if the pain is not managed by the non-steroidal anti-inflammatory drugs, topical agent, acetaminophen, then give opioids, including the tramadol, oxycodone. If it is not significant, use the intra-articular injection, duloxetine, which is a selective serotonin reuptake inhibitor, and reduce the pain. And the last, which is very expensive option, is glucosamine and chondroitin, but not significant. So these are the main therapy, main aim, goal of the therapy to relieve the pain and disability. Let us see the cases. A 60-year-old non-smoking obese woman presents to her primary health care physician reporting pain and stiffness in right knee. Pain and stiffness. The patients reported a past medical history of peptic ulcer. Yes, peptic ulcer. So you have to take care of the non-steroidal anti-inflammatory drugs. On physical examination, the right knee has no swelling or synovial effusions, and crepitus is noted on examination of passive motion. And the radiograph shows right knee joint space narrowing with osteophyte formation at joint margin. If there is osteophyte, it means it is in the case of osteoarthritis. What non-pharmacologic therapies would you be recommend? As we discussed, weight reduction and exercise to improve the muscle strength. And what is the initial pharmacologic treatment recommendation for this patient? Justify. Drug of choice, acetaminophen, paracetamol, 1000 milligram orally 3 to 4 times for 2 to 3 weeks. Why? The lack of knee inflammation on physical examination, and the patient had the past medical history of peptic ulcer, so we cannot give other, including diclofenac, ibuprofen. The best one is acetaminophen. What is the role of topical agent in the treatment plan for this patient? Which one do you recommend and justify? Capsaicin cream, which should be applied topically. Capsaicin is produce initial burning and sensitivity reaction. Need 1 to 2 weeks to start the action. You know this capsaicin? Capsaicin is a chemical compound that is isolated from chili peppers, spicy chili peppers, which is very hot. Capsaicin caused a burning sensation. Chili pepper, spicy. Recommended as there are no systemic effect on drug interaction with topical capsaicin cream, and it acts by depleting the store of substance P. Diclofenac gel or solution. Diclofenac, non-steroidal anti-inflammatory drugs, less recommended as it causes systemic side effect, and it acts by inhibiting the COX cyclooxygenase, decrease the prostaglandin synthesis and inflammatory mediators. Case 2, osteoarthritis. A 67-year-old woman present to her primary care physician with increased pain and stiffness in her left knee. Pain, stiffness, knee. She reports her left knee as weak, and she has difficulty getting out of bed in the morning and after sitting on the recliner for some time. She has tried acetaminophen 1000 milligram 4 times daily for 1 month without adequate relief. She also takes metoprolol, beta blocker, lisinopril, angiotensin converting enzyme inhibitors, and ranitidine, H2 receptor blocker for acidity, twice daily. Her medical history includes hypertension, gastrointestinal reflux disease, and osteoarthritis, and right knee replacement 2 years ago. So this is a case of osteoarthritis with hypertension and GERD. Let us see the question. Select and recommend a medication to provide adequate pain relief for this patient. Justify your answer. Now, here the two main problems for selecting the NSAIDs, because patient has hypertension and GERD. So patient has a high risk for the cardiovascular disease. If we change, example, if we change this acetaminophen to ibuprofen or maybe a diclofenac, then what happen? Then the cardiovascular disease risk factor will be increased and GRD will be increased. So in this case, we have to skip the acetaminophen and we have to use tramadol, which is opioid category, which is from opioid category. Or use naproxen plus proton pump inhibitor or misoprostol with careful monitoring of blood pressure and renal function. So in my opinion, the use of opioid pain relievers like the tramadol is the best option as compared to naproxen and misoprostol. Question second, if the pain persists, what another analgesic drugs can be used and for how long? If pain persists, with the use of tramadol, then try another opioid analgesics, which includes oxycodone or combination of oxycodone and acetaminophen therapy. Use as needed when there is a pain, and the long-term use of opioid should be avoided because it will cause addiction. Describe the available intra-articular therapeutic options that can be given to these patients. And for the intra-articular injection, we have hyaluronic acid, which improves the elasticity and viscosity of synovial fluid. We can use intra-articular injection of glucocorticoids, which includes the triamcinolone, methylprednisolone with lidocaine, which is local anesthetic, 1%. Intra-articular injections are given no more frequently than every 3 months. Glucocorticoids having anti-inflammatory activity, and hyaluronic acid will improve the elasticity and viscosity of synovial fluids. Can any glucosamine and chondroitin products be recommended for these patients? As we discussed, the glucosamine and chondroitin are the last option because they are expensive and not effective. So our answer will be no, not effective, expensive. Do you recommend continuation of the treatment in this patient during periods when symptoms are absent justify? No need, because these available drugs are just relieve the symptoms, which is most important is pain. These are not disease modifying agents. So no need if there is no symptoms. So this was about osteoarthritis. Still, we discussed two arthritis conditions, rheumatoid arthritis and osteoarthritis. Now we will discuss about gouty arthritis. In the gouty arthritis, there is Deposition of uric acid. Deposition of the uric acid, Gouty arthritis. I will show you. Yes. Gouty arthritis. If you see the image, there is an the Gouty arthritis. The goal of treatment is to relieve of the pain and inflammation. It is not necessary to lower serum uric acid immediately. Treat acute gout with non-steroidal anti-inflammatory drugs, colchicine or corticosteroid, and continue until the attack is terminated, 1 to 2 weeks. Non-steroidal anti-inflammatory drugs are the drug of choice, provided no contraindications, means peptic ulcer, renal failure, or heart disease. What is the problem with the colchicine? Colchicine also release the depress or suppress the inflammatory mediators, but diarrhea. The colchicine is responsible for the diarrhea. Let us see the actual cases which to treat the serum uric acid. A 50-year-old obese man presented with an extremely painful big toe. He has no other symptoms and there is no previous significant medical history apart from hypertension. Yes. Mushkil. Hypertension, painful big toe, for which he takes thiazide, benroflumethiazide, which is a diuretic, 2.5 milligram in the morning. And this is the problem because some drug also increases the serum uric acid, and this thiazide diuretic is one of them which increases the serum uric acid. On examination, the big toe is red, hot, swollen, and extremely painful on palpation. And blood pressure is still increased, 150 by 95. Blood result shows slightly raised C-reactive protein, and serum urate is high, 400 micromole per liter. A diagnosis of acute gout is made. Question: what initial therapy would you recommend to treat the patient's acute attack of gout? NSAID is drug of choice as naproxen and sulindac because they are effective with rapid onset, relieve the pain and inflammation. NSAIDs are safe for patients with stable controlled hypertension when given for only a few days and with close monitoring of blood pressure. So drug of choice is non-steroidal anti-inflammatory drugs. What risk factors could have contributed to the acute attack of gout? The patient drug: hyperuricemia, main risk factor for the gout, obesity, overweight, hypertension, and thiazide and loop diuretic because This thiazide and loop diuretic increases the serum uric acid level by volume depletion and decrease renal secretion of uric acid. And again, alcohol consumption, lifestyle. So this patient is on thiazide diuretic therapy, which also increases the serum uric acid and may leads to gout, acute attack. What lifestyle and dietary advice would you recommend for this patient to prevent further acute attacks of gout? Moderate physical exercise, gradual weight reduction. Yes, remember gradual, because avoid rapid weight loss as it forms the ketosis, which leads to increase in uric acid. Total daily purine intake should not exceed 200 milligram per day. Avoid shellfish, sardines, soft drink, alcohol. Limiting daily purine rich meats and fructose containing beverages and foods. There is one vegetable, if you know, the green color, broccoli. Broccoli, the green vegetables are very effective as a non-pharmacologic therapy to reduce uric acid. If you see the broccoli, widely used for the acute gouty patients. Should this patient placed on therapy to prevent further acute attack of gout? If yes, explain and why, and mention when to start with which drugs. If no, explain why. What is the question? Should this patient placed on therapy to prevent further acute attack of gout? The answer is no. Why? Because he has just one attack. No risk factors like family history, no kidney stone. Therefore, no need for the preventive drugs if once the attack is subsided. And also, these hypouricemic drugs, once started, should be taken for lifetime. What is the indication of urate lowering therapy? It means that if the patient has an acute attack of gout, it is recommended to subside by using only non-steroidal anti-inflammatory drugs 1 to 2 weeks plus lifestyle modification. And if the patient has only one attack, no risk factors, no need to take the urate lowering therapy. But if the patient, we will see what is the indication for the urate lowering therapy. See here, when we have to take this therapy, one or more attack within 12 months, or we can say 2 or more attack occurs per year, then we need urate lowering therapy. The patient has comorbidities at the first acute attack like urate trophy, uric acid stone, or chronic kidney disease, then we need urate lowering therapy. If we need to continue the medication that causes hyperuricemia, suppose diuretics, we need to continue like thiazide, aspirin, we need to continue cyclosporine, cytotoxic chemotherapy, levodopa, ethambutol, and pyrazanamide. These are indications. Plus family history of cardiac or renal disease. Then we need to continue urate lowering therapy. But here, our patient is on thiazide diuretic therapy. Then we need to continue? No. We can replace the drug. Instead of thiazide diuretic, we will give another antihypertensive drug. No need to continue the thiazide diuretic and no need to continue urate lowering therapy. So this question will answer, do you recommend modification in the treatment of hypertension in this patient? Obviously. If no, justify. If yes, explain why and mention the which drug. Yes, we need to modify the treatment of hypertension because thiazide diuretic should be switched to another antihypertensive drugs, because this thiazide is responsible for the volume depletion, decrease the renal secretion of uric acid, and hyperuricemia, acute attack of gout. Give the alternate. Which are alternate? Recommended antihypertensive drugs are losartan, angiotensin 2 receptor blocker, amlodipine, calcium channel blocker, as this patient is a stage 2 hypertension, which is treated by combination therapy, and both drug decreases the serum uric acid. How? Amlodipine, which is the calcium channel blocker, increases the GFR, decreases the serum uric acid. Losartan, which is angiotensin 2 receptor blocker, increase the renal excretion of uric acid by interacting with urate 1 protein in the proximal tubule of the nephron. So change the drug. Case 2, a 45-year-old. We have less than a minute. We will join the meeting again, one meeting again. So after discontinuations, request to join again. Thank you very much.